พี่ขอไฟหน่อยขอไฟหน่อยขอยืมไฟแช็กหน่อยดูดเองจริงๆเหรอไม่ให้ฮะจ่าเลยดูดไม่ดีนะเลิกดูดได้มันมียาฆ่าแมลงอยู่ในเมมบุหรี่ด้วยนะดูดแล้วหน้าแก่นะสูบบุหรี่แล้วก็ตายเร็วไม่อยากอยู่เล่นนานๆแล้วมันไม่ดีรู้เปล่าสูบแล้วเป็นทั้งมะเร็งปอดโรคโป่งพองเส้นเลือดในสมองแตกไม่ดีแล้วพี่ดูดทำไมล่ะคะ
Advance the 18-gauge introducer needle over the superior border of the rib and into the pleural space. Fluid or air should be aspirated to verify intrapleural position. Note, the needle should be introduced and directed with appropriate orientation, inferiorly or superiorly. When the appropriate drainage site has been identified, advance the soft J end of the wire guide through the needle and into the pleural space. The wire guide should pass through the needle and advance into the pleural space without resistance. Remove the needle, leaving the wire guide in place. Make a small skin incision slightly larger than the diameter of the chest tube. While maintaining the wire guide position, dilate the tract and opening into the pleural space by advancing, in sequence, small to large, the supplied dilators over the wire guide. Introduction into the pleural space is facilitated by rotating and advancing the dilators in the same plane of the wire guide to prevent its kinking. With the wire guide still positioned within the pleural space, advance the chest tube inserter chest tube assembly over the wire guide and into the pleural space. It is important to advance the chest tube assembly into the pleural space, maintaining its direction in the same plane as the wire guide. This will make introduction easier and avoid kinking of the wire guide. The distal end of the chest tube inserter should not be advanced beyond the distal end of the wire guide. Remove the wire guide and chest tube inserter, leaving the chest tube in place. It is important that all side ports of the chest tube be positioned within the pleural space. The chest tube can now be sutured to the skin and is ready for use. A chest radiograph to verify placement is recommended.
Asthma is a chronic long-term condition that can be managed but not cured. Asthma affects the airways of your lungs. It causes the airways to narrow and swell, resulting in wheezing and difficulty breathing. During breathing or respiration, air goes in through our nose or mouth to the upper airways, at which point it reaches the windpipe, which branches into two large bronchi to reach the lungs. The lungs are protected by the rib cage, which also contains the muscles that control your breathing. In asthma, the airways are oversensitive and easily irritated by certain triggers, called asthmatic triggers. Most people with asthma are described as atopic, meaning they have an allergic type reaction to external triggers, such as house dust mites, pollen, cigarette smoke, animal fur, and chest infections. However, for some people, the onset of asthma is unpredictable and may be caused by anxiety, stress, or even laughter. An asthmatic trigger causes the airway walls to swell and the muscles around the airways to contract. The airways narrow, and breathing through them produces a whistling sound called wheezing. Mucus is produced from the lining of the airways, which clogs up the narrowed airways further and causes coughing. This makes normal breathing more difficult, producing symptoms of asthma that can be mild, moderate, or severe and life-threatening, where hospital treatment is needed. The narrowing of the airways is reversible if the trigger is removed, or if the inflammation is treated medically. Therefore, preventative treatment is used and can be managed by the patient themselves. An acute asthma attack requires medical intervention, but the type of intervention depends on the severity of the attack.
So for this next test then, what we're going to be looking at is to see how fast you can blast the air out and how fast you can breathe it all back in again. So I'm going to start with you breathing normally on the tube for a couple of breaths. I'll ask you to take as big a breath in as you can, and then I'm going to shout, blow. As soon as you hear that, I'd like you to blow through the tube as sharp, hard and fast as you can for as long as you can. As soon as there's no more, a real big fast one into the top. So just to go through the technique then, normal, big deep breath, and then far as you can for as long as you can. But I will guide you through it as you do it. So when you're ready, if you'd like to pop those pegs on your nose for me, please. And just start with normal breathing. Neck and shoulders relaxed. Everything relaxed, and just gently in and out on the tube. That's good. When you're ready, I'd like to take as big a breath in as you can. And blow! All the way to the bottom. Keep this going. Keep it going. Just a couple of seconds more. Lips tight. Real fast one in. Come off and have a rest. Well done. Pop the pegs off there. Get your breath back. And we'll let you have a rest for a minute before trying another one of those. Well done.
pneumococcal carriage. This is accomplished by first diluting and quantifying the bacteria in the inoculum. In the second step, the volunteer is intranasally inoculated with Streptococcus pneumoniae. Next, the volunteer has a nasal wash on days 2, 7 and 14 after the inoculation. Finally, classical microbiology is used to determine if the volunteer is carrying the inoculated pneumococcus.